and of course, earlier delivery if indicated. Then for patients that were transferred past 37 weeks, it was just scheduled as soon as possible. And then all women who delivered before 37 weeks received corticosteroids for fetal lung maturity. Then through a computer-generated sequence, patients were randomly allocated in a 1-to-1 ratio on the day before C-section. The results were in numbered opaque envelopes. On the morning of C-section, the envelope was opened and allocation was unsealed. Patients allocated to the balloon group were transferred to IR, and the catheters were inserted via the femoral arteries and placed at the anterior division of the internal iliac arteries, and then immediately transferred to the OR for C-section. Unfortunately, neither participants nor surgeons could be blinded to group allocation. So as far as methods, both groups underwent general anesthesia and had a midline vertical incision. They had similar perioperative management. They got a transverse bundle incision plus or minus a transverse incision at the lower uterine segment. So those patients would have been ones who had conservative management, and the surgeons just needed better access to the placenta for removal. The decision to transfuse was made by anesthesiologists and surgeons based on hematologic assessment and estimated blood loss. Of note, CHIST was not routinely planned. After clamping of the cord, they received gentle cord traction. If this failed to remove the placenta, then they got a CHIST. However, if the patient had a strong desire for uterine preservation and the surgeons considered it reasonable, then they attempted manual removal of the placenta for conservative management. Conservative management was also considered if the placenta detached or partially detached. So in patients in the balloon group, after cord clamping, the balloons were inflated bilaterally with normal saline. If the patients got a CHIST, then the balloons were removed immediately post-op. And if they underwent conservative management, then the balloon was left in place for possible post-op UAE. All catheters were removed within 12 hours of placement, and then they were deflated whenever the bleeding was controlled. So for confirmation of accreta, it was considered confirmed if the placenta failed to detach. And then for the most part, placenta or fragments were sent to blinded pathologists to be analyzed. However, some patients who underwent conservative management with removal did not undergo pathologic exam for reasons not stated. Looking at outcome measures, the primary outcome was units of PRBCs transfused. Secondary outcomes, there were quite a few. So transfusion of other blood products, intraoperative EBL, cesarean hysterectomy, operating time, surgical complications such as bowel or bladder injury, post-op UAE, postpartum fever and infection, maternal ICU admission, length of maternal stay, results of pathologic exam, cost of hospitalization, neonatal outcomes, and then balloon catheter-related complications such as puncture site hematoma, thrombosis, embolic events, and vascular rupture. Looking at power, previous studies reported a mean or median transfusion of 4 to 6 units of PRBCs in women with placenta accreta. So a mean transfusion of 5 units with a standard deviation of 3.5 was assumed for the control group, with the two-sided alpha of 5% and a power of 80%. Enrollment of 48 women in each group was required to detect a mean reduction of 2 units PRBCs transfused to the balloon group. The number of participants was increased to 100 to allow for a 4% dropout rate. And of course, P less than 0.05 was considered statistically significant. Variables were measured in mean plus or minus standard deviation, median and range, frequency and percent where appropriate. Independent samples t-tests were used for normally distributed continuous variables. A Wilcoxon rank sum test was used for non-normally distributed continuous variables. A chi-square test or Fisher exact test was used to compare categorical variables. A relative risk with a 95% confidence interval was used for binary outcomes. And then finally, a post hoc analysis was performed for baseline characteristics and outcomes in women who underwent a CHIST. So results, data was collected from August 2017 to July 2018. Baseline ultrasound and MRI characteristics were comparable between the two groups. All women had had at least one prior C-section. Of note, the majority had only had one prior C-section, so 88% in the balloon group and 96% in the control group. Other factors that were looked at were maternal demographics, other risk factors for placenta accreta, such as parity or prior intrauterine surgery, also maternal comorbidities, and then ultrasound and MRI characteristics. Of note, there were no p-values or confidence intervals listed in this. So looking at the primary outcome, there in the balloon group, there was a mean of 5.3 plus or minus 5.3 units transfused compared to the control group, which was 4.7 plus or minus 5.4 units transfused with a p-value of 0.54. So the number of units transfused was not statistically significant between the two groups. Looking at secondary outcomes, there was no significant differences between the groups with regards to transfusion of other blood products, intraoperative EBL, rate of cesarean hysterectomy, surgical injuries, maternal ICU admission, length of maternal stay, operating time. There was, however, a significantly higher rate of postpartum fever in the balloon group, as well as a higher cost of hospitalization. Of note, no maternal deaths occurred. Post-op bilateral UAE was only performed in one participant in the balloon group. None had a relaparotomy. None had severe balloon-related complications. And there were 4 participants, 2 in each group, who had a platelet count of less than 50, but did not get a platelet transfusion, which 50 is the recommended threshold for considering transfusion of platelets. Neonatal outcomes were similar in the 2 groups. Only 38 out of 100 patients underwent cesarean hysterectomy, 22 in the balloon group and 16 in the control. Pathologic findings were comparable between the 2 groups, and then all of the 38 women who had a CHIST had a pathologic diagnosis of placenta accreta spectrum, so 7 with accreta and 31 with accreta. Looking at the post hoc analysis of those who underwent CHIST, the baseline characteristics were comparable between the 2 groups, and there was no significant difference in the mean number of units transfused, intraoperative EBL, or the rate of FFP transfusion. So this is similar to the overall analysis. So for discussion, looking at previous literature, previous systematic reviews and meta-analysis, and many recent retrospective studies have reported that intraoperative balloon occlusion did have benefits in reducing blood loss, the amount of transfusion, and the rate of CHIST with accreta. However, several case control studies did not find any benefit. There was a small randomized control trial with 27 participants conducted by Salem et al. That did show that pre-op placement of the balloon cap did not reduce the number of PRBCs transfused. So results very similar to this one, just a smaller randomized control trial. And then looking at the post hoc analysis, we showed that the balloon occlusion did not improve outcomes in women who underwent CHIS, and these results were similar to those reported by Shrivastava et al. And then Macri et al. Reported in a systematic review that vascular balloon occlusion was beneficial in reducing blood loss. However, there were significant catheter-related complications. So looking at the strengths of this article, it was a large randomized control trial that had 100 people with placenta previa and suspected accreta over a relatively short time period. There was adequate power to detect differences in the primary outcomes between the two groups. It did have strict inclusion criteria with reported ultrasound and MRI diagnostic criteria. And then the post-hoc analysis was performed in women who underwent CHIS with similar findings to the overall analysis. Then there was also a note that 98% of participants had a surgical diagnosis of placenta accreta. However, remember that this could just be made by intraoperative failure to remove the placenta, and then 70% had a histologic confirmation of accreta or procreta. So looking at limitations, this was an unblinded trial conducted at a single center. This makes it less generalizable to other populations. EBL was subjective, and there were varying provider thresholds for blood transfusion, which can lead to observer bias. The decision to perform CHIS was made intra-op instead of routinely planned per recommendations. This could affect the blood loss and the need for transfusion. Most of the participants in the trial had only had one prior C-section, like we talked about, and this was mainly because of the one-child policy in China that was in place till 2015. This causes a lowering of the generalizability to the higher risk populations, such as ours, with multiple prior C-sections. These patients had a baseline risk of 11% with the previa and just one prior C-section. So in conclusion, the intraoperative balloon occlusion of the internal iliac arteries did not reduce the number of PRBC units transfused in women with placenta previa and antenatally suspected placenta accreta. So what does this mean to us here at MCG? There's no clear evidence at this time to support the use of intraoperative balloon occlusion in women with accreta, and if we were going to consider it, then there would be need for a more generalizable study with a higher risk population, such as a higher number of prior C-sections, maybe a higher BMI, other factors. Question.
All right, so thank you for that review. I guess my question for you, Hannah, is how do you think this might change your practice?
So at this time, I would not consider balloon occlusion. I just don't think there's enough evidence to support the use and suggest benefit from it, but also with the risk associated with it, it's just not feasible, I guess, worthwhile.
I think this is a pretty hard trial to duplicate in other parts of the world because it's rare that you find a place that gets 100, plus cases of morbidity
in 1 year.
In 1 year, correct. Now, maybe all of these weren't true, what we would consider a placenta accreta, since a lot of these patients were managed conservatively and only had one previous C-section. So, but they do have the histologic diagnosis for a large percentage of them. So, but I think it is a spectrum of disorder, and I think the spectrum of disorder that they had was maybe a lower spectrum of disorder than what we see, especially at our institution and also throughout the rest of the United States. Do we have questions from the audience?
Yes. Yeah, very good presentation. So it looks like overall most of the study was reasonably well done, but To me, there seems to be one problem. What do you think is the biggest problem in this study?
I mean, I think one of the big things is that it couldn't be blinded. However, I don't see any way that it could have been blinded.
So what was the primary outcome?
Number of PRBC units transfused.
And so to me, it seems like, their estimated blood loss, if they're doing it subjectively, that's an issue. I mean, it's hard if you're doing it in different places all over the world. I realize that. But it's, quantitating blood loss probably would have made a difference in their transfusion rate. And if they knew how much blood was actually lost rather than estimating, as we all know, that's not very accurate.
Yeah, and there was no absolute criteria for blood transfusion. So if the anesthesiologist felt like, the patient needed blood, the patient got blood, but it wasn't like at a certain grams per deciliter of hemoglobin done by a hemostat, that they would decide. So it was a very subjective use of blood. There was no standardization. So, hopefully, that comes out in the wash with that many patients, but you can't say that for sure.
Thanks, Dr. Lehman.
Other questions?
No, just a quick comment. That was really nicely done, Hannah. I think, frankly, one of the, having done this for many years both ways, I really have not, at least in my clinical practice, have had much difference in terms of with or without balloons. But the only comment I would make sometimes is the speed and efficiency of doing the operation, which probably makes one of the biggest differences in these situations.
Do you think it makes a difference when there's GYN oncologists that have a high skill level that probably maybe balloons may not be as necessary, whereas maybe in people that are less skilled, the balloons would give them maybe time to, assess the situation or even get in a more experienced surgeon?
I mean, intuitively, I would probably say yes. And the other big thing with this paper was the fact that in China, because of one kid policy, there are not going to be too many people which are represented, say, in United States with 3 peats and 4 peats, where your chance of the accreta is more likely to be a per creta. So I think the patient population which we see, say, in United States is significantly potentially worse than people with 1 C-sections. And maybe the invasiveness of the patients, the cases that we see probably are a little worse than what you see in this trial. But I think perhaps that might make a difference.
Absolutely. Thank you.
All right. Give one more chance if anybody else has any questions or comments. Otherwise, we're going to move on to our next presentation. Okay, well, I want to thank Dr. Childs for this presentation. And we're going to have Dr. Monson come up, and he is going to present the article that deals with decision tree algorithm for route of hysterectomy. Dr. Monson is one of our PGY3s. We're excited to hear what he has to say.
Thank you, Dr. Jain. So as Dr. Jain said, I'm going to be discussing an article from the April edition of the Green Journal titled Prospective Implementation and Evaluation of a Decision Tree Algorithm for Route of Hysterectomy. And this is out of the Mayo Clinic. The study objective was to evaluate the rate of vaginal hysterectomy and the outcomes after initiation of a prospective decision tree algorithm to determine the optimal surgical route of hysterectomy. As a bit of background regarding vaginal hysterectomy, there was a study produced from the same institution at the Mayo Clinic that showed that the vaginal hysterectomy is the most cost-effective route. And they quoted an absolute rate of about $4,000 less for a total vaginal hysterectomy compared to a robotic hysterectomy. There is generally a low complication rate, and kind of the purpose of their study is in regards to the decrease in prevalence in the United States of vaginal hysterectomy, where in 2010, the rate across the US was about 20%, and had decreased down to 10% in 2013. And this is generally related to the advent of robotic surgery, which increased the use of laparoscopic hysterectomies, which increased from nearly 0 in 2007 to up to about 10% in 2010. Vaginal hysterectomy is the route still recommended in the committee opinion by ACOG, if possible, followed by other minimally invasive options, including laparoscopic and robotic-assisted hysterectomy, followed by total abdominal hysterectomy. Their purpose is to increase the frequency of total vaginal hysterectomies, and this was based off of the study that this group had also performed in 2017, where they created an algorithm for what they thought should determine the route of hysterectomy, and we'll talk about that algorithm shortly, but they compared this algorithm to the pre-robot time to the post-robot time, and if the algorithm suggested total vaginal hysterectomy, patients who subsequently did undergo a total vaginal hysterectomy had better outcomes than if they underwent a robotic hysterectomy when the algorithm suggested a vaginal hysterectomy. And this retrospective study showed that robotic surgery increased deviations from the algorithm, meaning that if the algorithm suggested that they have a vaginal hysterectomy, they ended up having a robotic or laparoscopic or abdominal hysterectomy. It increased the deviations from 15 to 25%. And if the algorithm had been followed and all patients who should have had a vaginal hysterectomy had a vaginal hysterectomy, they estimated that the 5-year cost savings at their institution would have been approximately $800,000. The outcome measures that they used, so the primary objective, they are evaluating the effect of this algorithm on the rate of total vaginal hysterectomies performed, with the secondary objectives being to evaluate short-term post-op outcomes after prospectively implementing a clinical decision tree algorithm, and then to determine the optimal route of hysterectomy, and to discuss the estimated effects on healthcare costs. Their study design was a quality improvement project based on a previous retrospective cohort study. And this included all patients who had a hysterectomy and they needed to have their evaluation for hysterectomy in the outpatient setting between November 24th, 2015 and December 31st, 2017, so about 2 years. That this included all patients who did not meet their exclusion criteria. So there was no blinding, there was no control group. To allocate their patients, they created their algorithm based on the algorithm that they had used in their previous study, based on 3 criteria. Number 1 was uterine size. So they created 3 different groupings. So this was less than a 12-week uterus, a 13 to 16-week uterus, and if a patient had greater than a 17-week or 500-gram uterus. Their history of laparotomy, including cesarean section. So in group 1 with the lowest or with the smallest uteri, and the history of less than or equal to 1 cesarean delivery or laparotomy, versus in the middle group, which we'll talk about. And then also included in this was vaginal caliber, mobility, and descent of the uterus. So to prepare for this, they introduced this prospective algorithm to their gynecologic surgery division in August of 2015, prior to implementation in November. They created 3D pelvic models with interchangeable 3D uterine models at 100, 280, and 500 grams. They introduced this at the division meeting so that everyone could evaluate and have a standardized way of evaluating uterine size. And then they also had these models available in outpatient clinic for reference during patients' evaluation and surgical decision making. They also evaluated vaginal caliber, mobility, and descent. They created a strict physical exam template to standardize documentation in the office and for exams under anesthesia. This included uterine size, uterine mobility, uterine location, high or not, and vaginal caliber. So in this decision tree, so group 1 included uterine sizes less than 12 weeks with less than or equal to 1 C-section or laparotomy, and an adequate vaginal caliber, mobility, and descent on outpatient evaluation would automatically be allocated to a total vaginal hysterectomy. The second group included uterine sizes between 13 and 16 weeks, or a smaller uterus, so 16 weeks or less, with greater than or equal to 2 laparotomies or prior cesarean deliveries, or if they felt like vaginal access based on caliber, mobility, or descent on an outpatient evaluation. Then they created an option for an exam under anesthesia, after which they repeated this physical exam. If the uterus descended halfway down the vagina with an adequate vaginal caliber, they were allocated to the vaginal hysterectomy, and if not, they were allocated to a laparoscopic or robotic hysterectomy. Or in group 3, with a uterine size greater than 17 weeks, the surgeons were allowed to decide whether they would pursue a laparoscopic or robotic hysterectomy or an abdominal hysterectomy. They did include several exclusion criteria. Many of these were cancer related, but if they also had other anti-incontinence procedures, if they were undergoing a cesarean hysterectomy, if they had adnexal disease, and they also included endometriosis in transgender patients, which had not been included in their prior retrospective study. They did that because the options that we have for endometriosis medically, and also because of the surgical complication or complexity with advanced endometriosis, and transgender patients because of the many factors that are going into that surgery. They also included this arm with the exam under anesthesia to provide a greater chance of pursuing a vaginal hysterectomy. There was not much statistical analysis in this paper. The continuous data was summarized descriptively with a mean and a median with interquartile ranges, and categorical data was presented as a frequency with percentage. And they compared the data from the retrospective algorithm to the prospective algorithm to evaluate its effect. For the results, the adherence to the algorithm did improve after introduction to the algorithm and introduction of these criteria. And the deviation from the algorithm decreased to about 12%, down from 25%, which they found in the retrospective study. Of those that began as vaginal hysterectomies, 99% were completed as vaginal hysterectomies and did not have to be converted to another route. They also evaluated the characteristics of these patients, and those highlighted are the ones that they discussed in the paper. The overall gist of it is that the groups were very similar. So the ages were similar at about 45. So these patients here are those that did have a total vaginal hysterectomy performed. So the leftmost column is total vaginal hysterectomy was expected and performed. The middle column was those that allowed for an exam under anesthesia, followed by a vaginal hysterectomy. And the last column is those that were expected by the algorithm to be a robot-assisted total vaginal or total laparoscopic hysterectomy or abdominal hysterectomy. However, when they got to the operating room, they felt that they could adequately perform a vaginal hysterectomy, which was then subsequently performed. So ages were similar. There was a high prevalence of a white population here with about 90%, 90+%, and a low BMI with an average of less than 30%. They do highlight here that they are able to perform vaginal hysterectomies on patients with a total parity of 0, so nulliparous patients at about 5 to 10%, and an even higher rate in those who had prior deliveries but had 0 vaginal deliveries in the past, at about 20 to 40%. They highlight that they were able to perform vaginal hysterectomies on those who had prior C-sections, including those who had had 2 or more C-sections. Those who were expected to have a vaginal hysterectomy and did have a vaginal hysterectomy had shorter operative times, but they don't perform any statistical analysis on this, so they are very similar times, and the uterine weights are generally smaller in those who had a vaginal hysterectomy performed, although those who were converted from a more invasive route to a vaginal hysterectomy did have slightly larger uteri. They did have a significant rate of uterine debulking at the time of surgery, and they do show a low prevalence of intraoperative complications, although they did have several bladder injuries that amounted to about 2%, and some post-op complications, including urinary tract infections. And they did have 2 patients who had to return to the operating room post-operatively. One was for bleeding and one was for an abscess. They did have a rate of about 3% that needed post-operative transfusions, and they highlight that all these patients were able to leave the hospital, or the vast majority of these patients were able to leave the hospital within 24 hours. The next group that they discuss are those that by algorithm would have been expected to have a total vaginal hysterectomy, but for one reason or another had a more invasive or different route, including a robotic hysterectomy or total abdominal hysterectomy. They highlight several characteristics about these patients, including that these patients did tend to have a higher C-section rate. The uterine weight was slightly larger, although they don't perform any sort of statistical analysis comparing this. And there was one bowel complication. I believe they had a rectal injury and a similar rate of patients returning to the operating room. But again, they had a very similar length of stay with about almost 87% of these patients going home within 24 hours. So this is the author's interpretation of the results. So this prospective algorithm is straightforward and clinically applicable. The algorithm helps determine those who are a priori candidates for total vaginal hysterectomy versus those requiring an exam under anesthesia, which are theoretically those patients who would be surgically more challenging. They expect that 55% of all hysterectomies would have an a priori total vaginal hysterectomy, which is much higher than the actual national rate of about 10 to 11%. And they did show that the retrospective study, which had found a deviation of 25%, they found that using this prospective algorithm decreased the deviation to less than 13%, which was less than their baseline when they used their retrospective algorithm prior to the advent of robotic surgery. Their interpretation was that the median uterine weight was 116 grams in the total vaginal hysterectomy versus 185 grams in the exam under anesthesia followed by vaginal hysterectomy, and that this most likely represents the vast majority of cases performed at a national level. The complications in vaginal hysterectomies were low, but they do mention that their surgeons with advanced vaginal surgical skills should safely perform vaginal hysterectomy who would otherwise be expected to go other more invasive routes per the algorithm. So when they showed those patients who had originally been filtered to be a robotic hysterectomy or an abdominal hysterectomy, that those with vaginal surgery skills could still perform those as a vaginal hysterectomy. And they state that in this cohort over these 2 years, the cost savings would have been about $657,000 if all of the expected vaginal hysterectomies had been performed. They state that their strengths, that this is a prospective study, there's a good education component, and that they included this modified algorithm with the exam under anesthesia option and expanded exclusion criteria. But they state that their weaknesses include an expertise bias with a long-standing history at their institution of vaginal surgery. And many of their surgeons are also urogynecologists or minimally invasive trained specialists. And the other weaknesses, they say, are a small number of deviations from the algorithm and a small number of poor post-op outcomes, which limited their power analysis. So they were not able to perform adequate statistical analysis, and that there's no control group because all patients were allocated to this algorithm. So their primary outcome was posed that they wanted to see if they could increase adherence to this algorithm to increase vaginal hysterectomies. So yes, they did show that implementing this algorithms and getting buy-in from the surgical room decision makers, they were able to increase their adherence to the algorithm. They showed and compared the short-term complication rates in their population and discussed the estimated cost of the algorithm deviation. However, I would say that while they did show those numbers, there was no real statistical analysis of the difference of the complication rates between the groups because they were not powered to do so. And then they also provide a theoretical cost savings, which is based on a study that was performed at their institution stating that it was $4,000 per patient, comparing a vaginal versus a robotic hysterectomy. But they don't actually analyze their cost savings at their institution over these 2 years. And the article that they are actually referencing for the $4,000 figure, they, in their article, frequently quote $2,253 as an adjusted cost savings, which they felt was more accurately stated, which would lead to a $360,000 savings over 2 years compared to the 650 quoted in the article. Other issues not addressed in this paper, that many institutions perform laparoscopic hysterectomies, not just robotic hysterectomies, and they don't really distinguish where these laparoscopic hysterectomies fall in their analysis. It does not seem like those are falling under the robotic hysterectomies, although they don't clarify that. And it seems strange that the laparoscopic hysterectomy would be included in abdominal hysterectomy, which is definitely more invasive. They don't address the national trend of decreasing exposure of residents to vaginal surgery, considering we have a minimum of 15 vaginal hysterectomies over 4 years of training. And they don't address that if we have surgeons who are not trained in these methods, the morbidity and resource utilization in surgeons who have a low surgical volume. Now, to compare this study to our population, so this population was a very homogeneous patient population. with a very relatively young age, average in the low 40s, but also very high prevalence of whites and a low BMI of less than 30. They had relatively small uterine weights, although they did have some that were up to 700 grams that were allocated to vaginal hysterectomy. But their surgeons were also very trained vaginal surgeons. This is from the retrospective study when they looked over several years. But their surgeons performed about 74% of their hysterectomies were performed vaginally, even prior to this algorithm, which is different than most institutions. They had about a 15% of their patients who were scheduled for hysterectomy underwent an exam under anesthesia at the time of surgery to determine their route. This is not standard practice here. We generally have our route already decided before we get to the operating room. We don't book the robot room and then be able to decide that we just want to do a vaginal hysterectomy. And looking over just the last 15 hysterectomies that were performed at our institution, although we did have one that was an exam under anesthesia prior to decision for route of surgery, but that was to determine laparoscopic versus total abdominal hysterectomy. So our difficulties with this is really access to robotic surgery and to the actual robotic surgery instruments, and then preparation of instruments and equipment, having our staff in the operating room be adequately prepared to perform vaginal, laparoscopic, or abdominal hysterectomy based on exam seems a little difficult. So I used this algorithm to look at our patient population. I included our GYN and UroGyn population, although some of these patients in reality would have been excluded from this based on UroGyn procedures, but also on endometriosis. So I looked at the last 15 hysterectomies we performed here starting 2 weeks ago so that we would definitely have their pathology results. 3 were scheduled as planned vaginal hysterectomies, which were all completed as vaginal hysterectomies, although 2 were laparoscopic assisted. 3 were planned as abdominal hysterectomies, and 1 was planned as a laparoscopic versus abdominal hysterectomy based on exam under anesthesia and was ultimately performed as an abdominal hysterectomy. And 8 were planned as laparoscopic or robotic. 7 were completed as planned, and 1 was converted to abdominal hysterectomy for anesthesia issues. And 3 of these were chosen based on the route by a combination of the UroGyn procedure, which determined the route of access. So using this algorithm on our patient population, all vaginal and all of these total laparoscopic or robotic assisted laparoscopic hysterectomies would have been allocated to the vaginal group. We had a 20% rate in these 15 hysterectomies, but which would have been about a 45 to 75% deviation from the algorithm, 75 if we're not including that the UroGyn procedure needed to happen as well. So really a 45% deviation from the algorithm, which would be a little bit higher than their deviation that they found. However, 40% of our patient population was Black in these 15 hysterectomies, and our overall uterine size was larger. Overall, our average uterus was 468 grams. Interestingly, our vaginal hysterectomy average was higher at 225 grams, whereas our laparoscopic and robotic hysterectomy was smaller at 92 grams. Our abdominal hysterectomy size was large, averaged at over a kilogram, and the smallest being 414 grams. So those seemed to be appropriately selected to be abdominal hysterectomies. So considerations for further studies that can make this study more applicable to us is implementing a similar algorithm or an adjusted algorithm at a center with more diverse patient and provider population, and considering a multi-center trial for generalizability. I think there are serious constraints given the patient population and the surgeon background with generalizing this paper, and discussing in the future possibly a more flexible algorithm that would include all minimally invasive surgery in a similar category, as opposed to lumping robotic hysterectomy and laparoscopic hysterectomy with total abdominal hysterectomy. And then also looking at studies to evaluate and discuss enhancing the education of residents to improve their surgical knowledge for minimally invasive techniques, outside of just pursuing a fellowship in minimally invasive surgery. Presentation. Do you have any questions?
Thank you, Evan. Very nice presentation. I guess, as you did, I think it was great that you looked at those 15 patients, and obviously I think our population varies greatly from the population that they studied. Do we have any comments or questions from the audience? All right. Well, I thank everybody for their attention. It is getting close to 8:30, so we're going to go ahead and sign off. And I think at this point, we'll be planning our next journal club shortly. Thank you.